evening, everyone. Myself, Dr. Vibha Singh. Thank you, IOS, for giving me this opportunity to present myself at this platform. Today's case presentation is ocular hypertension post-phakic IOL. It is a case report. 25-year female came to the removal of the spectacle. She is high myopic with spherical equivalent minus 14.50 diopter in right eye, in left eye minus 15.525 diopter. Best corrected visual acuity in right eye is 6/6. Intraocular pressure is 10 millimeter Hg, and left eye it is 12 millimeter Hg. Central corneal thickness in right eye is 544 micron, and in left eye is 530 micron. Corneal white to white in right eye is 10.8 and left eye is 10.6. Anterior chamber depth is 3.59 in right eye, and left eye it is 3.65. The angle assessment using a ASOCT and OP scan imaging was done. Preoperative angle assessment was done, so we can see it is 43, and in left eye, both eye it was in a normal limit. Considering the status, phakic refractive IOL was thus planned. Preoperative NDR laser iridotomy was done in both eye. Implanted acryl phakic IOL, as the number is just shown in a slide. Post-operative follow-up, post-operative day 1, IOP 2 hours after procedure, it is 18 millimeter mercury. After IOP in left eye, 2 hours after the procedure, it is 19 millimeter of mercury. Post-operative after 1 week, IOP was 12 millimeter of mercury, and IOP in left eye was 12. After 1 month, IOP was 28 millimeter of mercury in right eye, and left eye it was 26 millimeter of mercury. Vault height was 615, and vault height in left eye was 329 micron. So post-operative angle assessment was done. So we can see in the slide in both eye angle was within normal limit. So we have to think another school of thought. So there is some another underlying pathology which was causing increased intraocular pressure. IOP normal in immediate post-operative period, subsequently increase in absence of excess intraocular inflammation. Excess ICL vault height ruled out by a ASOCT. So anterior chamber angle was open. IOP returned to normal 3 weeks after stopping the steroid eye drop. So diagnosis was made steroid responsive glaucoma. Differential diagnosis was missed primary open angle glaucoma. The optic disc in high myope usually tilted, large with a peripapillary atrophy, high myope predisposition to open angle, and steroid-induced glaucoma. Our patient had small eye as predicted with a corneal white to white measurement along with the high myopia. The chances of development of glaucoma increased manifold. So conclude the topic, identification of underlying cause of raised IOP. So crux of the management is treatment of underlying cause, retain viscoelastic, conservative treatment with anti-glaucoma medication or AC wash to remove the viscoelastic. If it is steroid responsive, stoppage or shifting to lower potency steroid, pupillary block glaucoma, enlargement of the iridotomy or surgical iridotomy. It was if malignant glaucoma, peripheral irido-zonulo-hyalido vitrectomy along with the AC reformation, explantation of the IOL filtration surgery are successful in controlling IOP in refractive cases. And take-home messages, if high IOP and still happy patient, rise in IOP detected earlier, treated promptly on every visit. Post-operatively, IOP measurement, angle assessment, and vault height measurement is essential. Extra careful with high myope and small eyes. Thank you. Yes. Central corneal thickness was 550.
Anybody wants to ask?
Meanwhile, the next speaker can get ready on the dais this side. We have Dr. Asmita. Do we have Dr. Asmita? Yeah. Please get ready.
Was it there in your presentation?
Yes, ma'am, it was in the presentation.
Okay. So other thing is your diagnosis was ocular hypertensive glaucoma.
Ocular hypertension. So, ma'am,
No, you have mentioned glaucoma. Why did you mention glaucoma? That's not the diagnosis.
If the patient come with a high pressure, then first we suspicion of the glaucoma. If patient come with a high intraocular pressure, we just have a suspicion of glaucoma, ocular hypertension, because angle was normal. It is only a steroid responsive and disc and all thing was normal. So we just
So
after
Vibha, ocular hypertension is not equal to glaucoma. It's not glaucoma, right? And were there disc changes? Disc changes were there?
not there.
So you cannot comment, I mean, you cannot label a patient as glaucoma. Glaucoma term has to be used only if the disc changes happen. So it was actually a case of ocular hypertension. It's not ocular hypertensive glaucoma, okay?
Okay.
Right, thank you.